Well, welcome everyone to the Canadian Cochrane Network and Center's Winter 2010 Research Webinar Series. My name is Adrienne Stevens and I am the Education Coordinator for the Canadian Cochrane Network and Center. This is our first session of the Winter 2010 series, and so Happy New Year to all of you. A few of you have been able to join us again from the Fall 09 series. So welcome, and welcome to those of you who have joined us for the first time. And I'm pleased to say that we have folks who have registered for this session from across Canada, from coast to coast. Throughout the United States, we have folks from Croatia, Peru, Venezuela, Germany, the Philippines, and Fiji. So welcome to all of you who've joined. I just want to take a moment to acknowledge the funding agencies of the Cochrane Center and entities within our Canadian network. Those funding agencies being the Canadian Institutes of Health Research and 6 of the research institutes, as well as to the Canadian Agency for Drugs and Technologies in Health. Thank you for your support during this funding period. And I also want to extend a special thank you to the Pan American Health Organization, that is the regional office of the WHO for the Americas, to their Research Promotion and Development Division for providing Illuminate Live to be able to conduct these webinars. Just a quick mention that the next Canadian Cochrane Symposium is taking place in May of this year. The dates are the 19th and 20th, and we have some pre-symposium workshops as well on the 17th and 18th. The call for abstracts is currently open, and abstracts are due on the 12th of February, and registration is being launched this coming Monday. So we look forward to your participation and welcome all of you to join us. Just a few housekeeping items before we get started with today's webinar. I just want to bring your attention to the participant window where you will see your name as well as the other participants in today's session. If you wish to ask a question, as you can see on the whiteboard, you can click the raising your hand button, and then that will signal to the speaker that you have a question. We ask that you hold your questions until the end, and that's when she will ask them. During the session, we will have a chance to use the emoticon, so even now, if you wish, you want to send me a happy face through the participant window and just say, hey, I'm having a great day. You can use your emoticons as well there. If you wish to initiate applause, great, thank you for those happy faces, wonderful. If you would wish to initiate applause to the speaker for today's session, then you can do so as well, the emoticons. I will also bring your attention to the polling features of Illuminate. On the whiteboard you will see a check mark and an X. I've actually set up today's session, as you can see under your window, an A through D, and we'll use that at some point during today's session. So when it's time to cast your vote for the polling, all you simply do is select one of A through D, and just so you know, you won't see your answer appear on the participant window. That's because I've set the settings such that your answer is anonymous, and then when we go to put the aggregate results on the polling board, then we'll do that at that time. So you just simply have to make your selection, and then it will register through. Just to bring your attention to the chat room, if you're not joining us today with a microphone and wish to send your question or a message to the chat room, you can do so there, and I'm pleased to say that during today's session we'll have a chance to sort of do some idea generation, and I will open up the chat room, and at that time you will be able to see each other's comments as we go through the session. And as you can see, we set this up through Illuminate, so we have one audio activated at a time. And if you wish to ask a question or contribute to the discussion at that point, and our today's featured speaker will prompt you with that. And when you raise your hand and she prompts you to ask your question, all you simply do, as you can see on the whiteboard, is you select your audio button. You can make your comment or question, and then I do remind you to release your audio, and then the speaker can get on to answer your question. So I am pleased to introduce today's featured speaker. That is Erin Ueffing with the Campbell and Cochrane Equity Methods Group. you'll notice that they've undergone a name change, so congratulations to you. Formerly, they were the Cochrane Health Equity Field and Campbell Equity Methods Group, and now their name has changed over to the Campbell and Cochrane Equity Methods Group. Erin Ueffing is the administrator for that group. She has a background in epidemiology and health sciences. She has a bachelor's degree in health sciences from the University of Western Ontario and a master's degree in health sciences from the University of Toronto with her specialty in epidemiology and community health. At the end of her graduate training, she completed a practicum at the Ontario Tobacco Research Unit where she studied smoking and bullying in Ontario adolescents. Other past research projects include home care workers' perceptions of the labor market and hepatitis C rates in first-time blood donors. And she has been with the Cochrane Equity Group since 2007. So she's today's main speaker. We're also joined in the webinar room by Jordin Pardo. He joined the Center for Global Health in 2009. He began his involvement with the Cochrane collaboration in Barcelona, where he's from. He's trained as a journalist, but has been working in health research since '97, mostly with the Ibero-American Cochrane Center. There he developed his interest and experience in distance learning initiatives, knowledge translation activities, and played a major role in launching the Spanish version of the Cochrane Library and the Spanish version of the TRIP database. In addition to working with the Center for Global Health, he continues to work with the Ibero-American Cochrane Network. And I'm pleased to say I've had an opportunity to work with both of these folks in previous training events, and so I'm glad we're able to work again today. So without further ado, why don't you join me in welcoming Erin Ueffing.
Thank you very much for that kind introduction, Adrian, and thank you so much to everybody for joining us today. I'm really excited to talk with everybody about equity today and get some of your views and some of your input on how equity can help you and how you can help equity. I'm presenting today on behalf of Peter Tugwell, Mark Pettigrew, Vivian Welch, Betsy Christensen, and Jordin Pardo. In today's discussion, I'll give a brief introduction to our group. We'll talk about what is equity, why is equity important, who is equity important for, and who cares about equity, when do we consider equity in systematic reviews, and what sort of methods we can use to include equity. As Adrian said, our group has recently changed our name to become a methods group. Our group is really focused on developing methods around systematic reviews and equity, looking to improve the relevance and quality of systematic reviews for policymaking, and we work on developing explicit methods for how to consider equity in your review and what that means. We develop criteria for when these methods should be applied. You may have seen this slide before that says the poor are getting poorer, but with the rich getting richer, it all averages out in the long run, you know. We disagree with this statement. What we find is that systematic reviews can often hide the effects of certain interventions in disadvantaged populations. By looking at an average and a pooled result, we may not see whether an intervention is actually effective in the group of interest. So we would advocate for the use of subgroups where appropriate and consideration of equity effects. So what is health equity? We use the definition from Margaret Whitehead, who said that the term inequity has a moral and ethical dimension. It refers to differences which are unnecessary and avoidable, but which in addition are also considered unfair and unjust. In other words, if you look at this diagram, we're really focusing on that bottom box there, those differences that can be changed or avoided and that we subjectively judge as unacceptable and not right. So why is equity important? Why are we concerned about this? Well, Margaret Chan from the WHO has said equity in health matters. It matters in life and death ways. Also from the WHO, Sir Michael Marmot of the Commission on Social Determinants of Health has said that achieving health equity within a generation is achievable. It's the right thing to do, and now is the right time to do it. So there's really a push from international, national, not-for-profits, from the private sector, really moving forward on addressing issues of equity. particularly from policymakers. So if equity is so important, who's it important for? Who does it matter to? And here I'd like to invite your involvement. If we're talking about equity and we're talking about disadvantaged populations, what sort of populations would be considered disadvantaged? So I'd like to invite you to please either use your audio or feel free to use the chat room to suggest what sort of groups might be disadvantaged. Any ideas that come to your mind in the reviews you've done or from general knowledge. I see that Gary has written in ethnic minorities. That's terrific, yes. And housewives, for example. Very interesting, looking at whether people are employed or what sort of jobs they have or what sort of work that they're doing. I see that Rebecca's written in children. Also crucial, looking at both ends of the age spectrum. Very important. Donna's written in people with disabilities. Very true, and being disabled, of course, in any way, can predispose you to other difficulties or make it more difficult to access health and so forth. Lori's mentioned newcomers, immigrants and refugees. Very important, groups who might not know where to access health or how to access health, or might have particular health issues that practitioners aren't aware of. See, Carmela's written in less educated. There's low-income populations from Donna. Women, looking at issues of gender and sex. Native Americans and Canadians. Those are some fantastic suggestions. Thank you so much, everybody. And I see the elderly. Fantastic. So as you can see, there are all sorts of groups who are disadvantaged. So thank you so much for those suggestions. We use a framework in our group called Progress, Progress Plus. Tim Evans and Hillary Brown came up with this acronym Progress to describe place of residence, rural or urban, race, ethnicity. I remember somebody suggested ethnic minorities. We heard the recommendation of housewives, looking at occupation or being out of work. Issues around women and men, boys and girls, gender and sex. We heard all sorts of these issues coming up from what you're describing here. The SES being socioeconomic status, low-income populations. All of these groups, depending on the context in which they're found, could be considered disadvantaged. The plus in our Progress Plus came from Josephine Kavanagh and her group in the UK, who were looking at issues such as age. We heard children and the elderly being mentioned, sexual orientation, and previous disability. So those are the groups that we try to consider when we're talking about equity and disadvantage. So my next question is, who's concerned about this? Who is this an issue for? And I'd like to invite you again, if you could use either the chat room or the audio, who might be concerned about the results for the disadvantaged? Who might be worried about systematic reviews and equity? I'd invite you to participate by making any suggestions of groups that you think might be interested. CIHR from David Morrison. For those who aren't from Canada, CIHR is one of our major funders and a major funding institute across Canada for all sorts of health research. That's Canadian Institutes of Health Research. I see decision makers from Kim. Carmela suggesting the disadvantaged themselves. Of course. Lori, policy decision makers. These are some fantastic suggestions here. And you're right, there's an interest across the board in equity. All sorts of different groups have been putting their hands up and saying, we'd like to make this one of our strategic priorities. Or people saying, have you considered our group? Our needs don't seem to be being met. All of these people are stepping up. And we use a different framework to describe these sort of groups. The 6 Ps. So we look at policymakers, I heard that mentioned. We look at practitioners, people who work with the disadvantaged. We look at the public and the press, the private sector, and patients. And of course, as Dawn is mentioning, society as a whole. All of these people are concerned about equity and are interested in seeing systematic reviews that address equity issues. So our next question is, when? When equity? When does equity matter? And when does it apply to systematic reviews? Some of you who've registered for this session suggested reviews. You proposed ideas for reviews that maybe you're doing, or reviews that you'd like to do, or reviews that you think would be exciting to do. So I wonder if you could describe for me, listing these reviews here, these are the reviews that were suggested, how or why do you think that equity is being considered in them? So when is equity being considered? In, for example, flossing for oral health. So I would invite either the people who've submitted these topics or anybody else, if you'd like to comment on why this was proposed from an equity perspective, when equity is going to be considered in your review. So if anybody could use the chat room, or feel free to put your hand up. We'll open the chat room now for anybody who'd like to contribute an idea of when equity is relevant in these review topics. I see that there's one coming in, so I'm just going to wait a moment for that response to be finished typing. Thank you very much for your suggestion, Lori. That's terrific. Lori suggested at the question stage. So when is it being considered? Absolutely, right when you're forming that question, at the beginning of formulating your review. Thank you so much, Lori. Any other ideas? Any other thoughts of when equity should be considered in your review? For example, looking at non-pharmacological interventions for preventing secondary vascular events. I see somebody else is writing in, so as soon as they finish typing, I'll read out their response. Looking at consensus processes. That's an interesting review for equity. Looking at how equity applies in professional practice. Terrific idea. David Morrison has suggested when analyzing the data. Absolutely. Absolutely. When assessing the data from a systematic review, you want to consider to whom it applies and how you're going to analyze that data. For example, are you going to be doing a subgroup analysis? Are you interested in separating out your data by disadvantaged populations? Terrific idea. Thank you so much, David. And I'm waiting for another response to come in from Donna. These are some terrific ideas. And as we're seeing, equity can be considered at many different stages of a review. We're going to give it another moment or two, and then we'll continue on. Donna's written in looking at who is included, excluded in the body of research. Absolutely. Both at the primary study level, you're right. Who is included and excluded in those primary studies, and then making sure when you're describing your review that you've very clearly described who you're including or excluding at the review stage. That's fantastic. Thank you so much, Donna. I'm going to move forward to where we thought maybe equity was considered. We went through the Cochrane library and we pulled out some reviews that we felt addressed equity. So you can see them there, Christensen 2007 and so forth. Some of these reviews were at a broader upstream level, such as encouraging rural practice, whereas others were much more downstream and at the individual level, such as school feeding for disadvantaged children. All of these reviews here have considered equity at different stages. So for example, the peer-based strategies for women with HIV/AIDS looks at equity in terms of the population who's involved, a group that's already has a disability, and looking at the context. Where are these women going for peer support, and how are they approaching that? If you look at Simon Lewin's review, which was addressing lay health workers, he looked at interventions that were intended to reach the disadvantaged, and he also considered the context in which those interventions were being delivered. If you're interested in learning more about any of these reviews, I'd be happy to email them to you or discuss them afterwards. So if we've decided when equity is important at different stages of the review in different ways, how do you include equity? How do you bring this in, and what can equity do for you? Well, how you measure that gap makes a difference. As you can see in this cartoon, the gentleman's saying, interesting. The gap between the rich and the poor is not as great as we thought. Well, that depends on what measurement scale you're using and how you're measuring it. And it's very important to outline how you're measuring equity in your review. So this leads into some of the methods work that we're doing and some of the different ways that equity can be considered. So a couple slides ago, I gave you a slide that identified reviews in the Cochrane Library addressing equity. And as we explained, equity reviews can look at interventions targeting disadvantaged populations, such as the school feeding review, or they may consider the context in which interventions occur and ask, will this intervention work in the poor? Finally, equity reviews may attempt to address the gaps and gradients between advantaged and disadvantaged groups. So I'd like to invite you to a vote regarding equity and how you can consider it. My question is, how are you addressing equity in your review? Or which approach would you be most likely to take? You can see the choices listed there, A, B, C, and D. I'd like to invite you to vote on which approach you would be most likely to take in a review that you would conduct. I can see a few votes coming in there. We'll give you another moment to cast your vote. So again, what we're looking for here is if you were to do a review that was considering equity issues, what sort of approach would you take? Would you look at a gap or a gradient? That is the differences in health. Would you look at a targeted intervention? That is an intervention that explicitly is aimed at people who are disadvantaged. Would you be more interested in the context, where the interventions are taking place, and what sort of people and populations are involved? So we'll give you just another moment. There's no correct answer here. We're really looking for what you're most likely to do. So there's no correct, there's no right, there's no wrong. Thank you very much, everybody. Adrian's just posted up the aggregate results there. And as you can see, there were more people who said targeted interventions and context than gaps and gradients. We didn't find this surprising, actually. Addressing gaps and gradients in a systematic review can be problematic because many interventions are not aimed at changing those gaps and gradients. It's very difficult to arrange an intervention to do so, whereas a targeted intervention or considering context may be easier to do from an equity perspective in terms of systematic reviews. So I'd like to move on to 7 challenges that we have around systematic reviews in addressing gaps and gradients, targeted interventions, and the context. We've been working with the WHO Commission on Social Determinants of Health, one of their knowledge networks, the Measurement and Evidence Knowledge Network. We've developed guidance around systematic reviews and equity. And these are the 7 places where we thought that equity can be addressed. The main challenges for systematic reviews: formulating the review question, defining the population, deciding on the appropriate study designs and the outcomes of interest, process evaluations and understanding context, analyzing and presenting data, and judging the applicability of results. I'd like to describe a little bit about what each of these means, and then I'd like to work through some examples of systematic reviews that you folks have suggested, and one in particular that we thought might be of interest to the group. In terms of formulating the review question, somebody suggested this was an important part of when to consider equity, and that's absolutely so. Our group is developing work around logic models, looking at when and how you feel equity might be involved in the intervention, looking at the proposed mechanism of action, how that intervention is expected to work, and how equity might be involved in that. So we're using work from the Centers for Disease Control and Prevention in the USA to describe logic models and to develop a model that we would suggest for inclusion in systematic reviews. Regarding defining the population, who are you including in your review? For whom is the intervention relevant? Are you doing a subgroup? And if you're including somebody who's disadvantaged, how do you define that group? When we looked back at progress, people were using all sorts of different words to describe disadvantaged groups. So it's really critical to define that population clearly and carefully so that anybody reading your systematic review knows whom it was conducted for and to whom it'll apply. Looking at the appropriate study designs. RCTs for systematic reviews, of course, but there are many systematic review questions for which RCTs might not be appropriate. For example, complex health interventions or interventions in public health and surgery. For those interventions, you may need to go beyond the RCT and include different study designs to address equity issues correctly and importantly. Defining the outcomes of interest. Somebody mentioned that it's important to involve disadvantaged people themselves. Those are the people who care. Of course. So what outcomes are of interest to them? What outcomes are they concerned about? Maybe they're more concerned about quality of life, for example, than a particular measure on an X-ray. Looking at process evaluation and understanding context. Understanding where the intervention takes place is critical to knowing whether or not it would work for a disadvantaged population. So for example, there are some drugs that are too expensive to be purchased easily in low and middle income countries. There are some interventions that aren't available in certain religious settings or in certain cultures. Understanding that context is crucial when doing your review for equity. David Morrison mentioned analyzing and presenting data. Absolutely. Looking at subgroup analyses and how to interpret that data, how to read it and how to separate it. Last, judging the applicability of the results. To whom will your results apply? Now, I'd like to turn it over to you for your involvement again. We've taken each of these 7 main challenges and put a different slide on them. And I'd like to ask you, for each of these challenges, in the reviews that were suggested, or if you have a new review, or if you have an idea, how could you address equity? How would equity be relevant, for example, for appropriate study designs? Or in the specific reviews that you've suggested, how did you approach this? What angle are you taking? So I'd like to open the chat board and the audio to anybody who'd like to participate in how formulating the review question can be relevant for equity, how your review could address this from an equity perspective. I'm just waiting for a couple of people to type in there and waiting for a couple of comments to come in. In the meantime, talking about logic models, our group here has been working with immigrants and refugees to develop guidelines for primary care practitioners. What we've been doing is developing recommendations for how primary care practitioners can offer preventive and treatment services to immigrants and refugees in their practice. So we've developed logic models showing how something as non-equity seeming as depression or as hepatitis C, how equity can play a role in that. And so we've used logic models to illustrate the connections between treatment and receiving the right diagnosis at the right time and moving forward. I'm waiting for Damien Francis and David Morrison to finish typing, waiting for a couple of comments from them. One review that we were thinking of was the vancomycin for nosocomial pneumonia. At first glance, this might not appear to be an equity review. It's very, very downstream. It's very clinical. It's very biological. It might be difficult to see how equity could have a role in a review such as that. However, there are many different, of the 7 different challenges, there are many different places where equity needs to be considered there. I see that David Morrison has written in a comment saying that he has a subgroup analysis looking at outcomes in private versus public institutions, HMOs. He's saying this is more for question 2, which is defining the population. David, I wonder if you would have a moment to explain a bit more about that. So we have a subgroup analysis looking at outcomes in private versus public institutions, or HMOs. So defining the population, looking at who the review is relevant for and who's being included, both at the level of the primary studies and at the systematic review level. I'm just waiting for David to finish typing there for us. And waiting for Damien as well. While David finishes writing, I see that Damien's written in preschool feeding for improving health among infant and young children, a subgroup analysis to look on groups from both ends of the SES spectrum. Fantastic, Damien. I understand that that's a review. I believe you're working with Betsy Christensen and some folks here on that. Damien's here in Ottawa for 6 months, visiting from Jamaica. And you're right, looking at who is included in that preschool feeding, infants and young children, you're very clearly defining which population that review is relevant for. And I see that David Morrison has written in saying, we're looking at interventions to increase prophylaxis for VTE. However, funding to implement these interventions varies widely between public and private care, VTE being venous thromboembolism. Thank you very much, David. And absolutely, the funding would be very different. So looking at whether the interventions are in public and private care would be crucial. And looking at which populations are included, because often the populations, of course, that are receiving private care would be different than those receiving public care. So very crucial issue. Thank you very much for your comments on that. I'm going to move forward to the next item, which is number 3, deciding on the appropriate study designs. I wonder if anybody in the group has used study designs beyond RCTs for their reviews, or have RCTs been the focus thus far? Looking at vancomycin for nosocomial pneumonia, of course, RCTs will be of crucial importance. However, including data from observational studies to address harms and benefits may be necessary as well. Does anybody have any suggestions on other study designs that could be included for equity? I see that Damien's just writing in right now, so I'll wait for him to finish. CCTs, controlled clinical trials, and ITS, interrupted time series, will be used in our study. Fantastic. So looking at before and afters, I wonder, as well? I'll wait for a response from Damien. Say yes or no. Yep, absolutely. Before and after studies being included. David Morrison says that he's also using before and after studies. It's terrific. It's interesting to see how in Cochrane and Campbell, systematic review methods are evolving beyond the RCTs to look at non-randomized study methods. Our group is actually doing some work on this with folks from Cochrane and Campbell to look at how to include those studies in systematic reviews. Is there a difference in terms of what biases you need to consider? So thank you very much for those suggestions. Yes, and David Morrison noting that you have to adapt your study bias. Absolutely. Absolutely. Very true when looking at different methods to include. And I'm waiting for Dario to type in as well. Response from Dario coming up. Thank you so much for your participation, everybody. I really appreciate it. And I see Dario asking how non-RCTs are addressing equity issues. Thanks for your question, Dario. As an example, non-RCTs often address topics that are very relevant for equity at the public health level. So for example, the Cochrane Public Health Review Group often addresses complex upstream interventions that look at policies. And those policies are often aimed at disadvantaged populations or trying to reduce the gap between those advantaged and those disadvantaged in terms of public health access and vaccinations and interventions at the population health level. I don't know if that answers your question, Dario. I'd be delighted to talk to you a bit more about that. And if you'd be interested in learning more about our non-randomized studies work, we could discuss that as well. Waiting to see if anybody else is writing in there. Looks like a no, so we can move forward. Looking at issue 4, identifying outcomes of interest. In terms of equity, looking at those outcomes that are of interest to patients, making sure that patients' needs are met when the studies are being done, and ensuring that patient-important outcomes are included. There's a group called OMRAT, Outcome Measures in Rheumatology, that looks at patient-important outcomes and which outcomes are important across rheumatological disorders. We're working with groups there to bring an equity perspective on those outcome measures as well. Does anybody have any ideas or suggestions in terms of outcomes of interest? How equity might be considered in your review? I'm waiting for a response from Dario. Thanks, Dario. Does anybody else have any suggestions? David, it sounds like your review is progressing. I see Dario's written in including consumers in defining those outcomes. Fabulous. Very important to get the consumer input. There's a lot of work in Cochrane looking at consumer involvement and consumer participation, particularly around plain language summaries. and involving consumers in doing peer reviews and looking at Cochrane reviews, particularly the musculoskeletal group, I see that Donna has said including community level effects, especially in public health research. Absolutely. Looking at the effects for the entire community, not just the individual. Very important for public health interventions. And Donna, I wonder if you might want to, I wonder if you could elaborate a bit more on how that's relevant for equity or fairness in terms of the subjectivity, in terms of how we can avoid or prevent health differences. I'm going to move forward to the next slide, which is looking at process evaluation and understanding context. Context is often where equity ends up being discussed in a review because, for example, there may not be sufficient data to do subgroup analyses, or the outcomes or interventions might be very biological and unchangeable in terms of an equity perspective. It's understanding the context of those interventions that we become very concerned about. I'm waiting for Donna to write in. Thank you very much, Donna. Looking at the context of reviews is crucial. For example, looking at low and middle income countries. Looking at whether a systematic review that was done on white, balding, middle class men in North America might apply to a group that's in, for example, sub-Saharan Africa, made more of younger women. Looking at whether that intervention is going to work. Are there issues around supply chains? Are there issues around whether the intervention is culturally acceptable? Maybe it wouldn't be preferred in that community. Maybe it's not acceptable to them. One thing that Jordin is mentioning to me is that the intervention might not be available. It might be too expensive, it might not be licensed yet, it might not be accepted, or it might not be something that local practitioners are perhaps trained to perform or do or offer. So understanding the places where those are going to be relevant is crucial. Moving on to number 6, looking at analyzing and presenting data. Thank you very much for mentioning that, David. You mentioned that that this is a crucial area for when to consider equity, and it is indeed around subgroup analyses. Looking at to whom the population, the intervention will apply is crucial, and looking at when the results of the systematic review will apply are also crucial. Our group advocates for subgroup analyses to be identified at the protocol level, recommending that identifying them after the fact could be considered data dredging, just looking for an effect without a reason. This is also why we advocate for the logic model, to show where and when you feel that equity and subgroups are applicable. So we would definitely recommend subgroup analyses when appropriate, when pre-identified, and when there's a reason for believing that that particular disadvantaged population might have a different result from that intervention. Finally, the last issue is judging the applicability of the results. When will those results apply? And I wonder, for those of you who are working on systematic reviews right now looking at equity, how are you deciding to whom your results apply? When you're looking at your implications for practice, when you're looking at your implications for further research, is there a way in which you're considering to whom your populations will apply? I'm waiting for a response from David. Thank you, David. Does anybody else have anything that they'd like to conclude? Anything that they'd like to offer from their reviews? One thing that we'd like to consider is simple solutions. For example, providing enough detail on how the interventions are delivered to help later in the implementation. Thank you very much, Jordin. And I'm waiting for a response to come in from Laurie Greco as well. And waiting for a response from Damien. When we were considering the vancomycin for nosocomial pneumonia, this is an example recommended by somebody who's participating in the group. One thing that we considered was where this intervention is being delivered. Nosocomial pneumonia in a hospital. Depending on what sort of hospital you're in, there may be higher rates of antibiotic resistance. There may be different rates of comorbidities. And for example, in some settings, hospital patients might have higher rates of comorbidities such as tuberculosis that would interfere with their nosocomial pneumonia. So understanding where the intervention is, where the disease is, and in whom it's more prevalent is also relevant. Lori's noted that it's really important to report on information about the context of the review to help decision makers determine relevance and applicability. Absolutely. If a decision maker is asked, the famous question, if you had $1 million, where would you be investing your money? Understanding where the review took place and understanding the context of the intervention is crucial for them to know whether it would apply to their population, to their setting, or their community. Thank you so much for that, Lori. And I'm seeing that Damien's put in identifying pockets or groups that would benefit tremendously from the interventions. Very true. There are some groups who might actually benefit more. There are some interventions that improve the health of the disadvantaged at a higher rate than the advantaged. Of course, there's also the reverse, and identifying in which circumstance each situation would apply is crucial. Thank you very much for those suggestions. I really appreciate that. I'm waiting for Carmela to type in her reply, and then we'll move forward. And I see Damien's also typing in an answer as well, and Donna. So thank you very much for those. We'll just wait a moment for them to come in. Thank you very much. I see a couple of answers have come in. Carmela has said applicability should be led by adapting, not necessarily adopting. Very good point. Very good point. So I gather you're saying that that adapting an intervention to a particular situation might be more important or might be more relevant and appropriate rather than simply adopting the intervention as it is in its entirety. I see that Damien's written in as well, saying that he wonders if from the review one could also identify specific methods of delivery that work. Absolutely. Doing a process evaluation is, I believe, our point 6, looking at how the interventions are delivered and how different methods of doing that work better than others. Donna's written in as well, when access to the treatment or intervention might not be equal and would therefore widen inequities. Absolutely. Absolutely. Interventions that increase the gap, inadvertently, of course. This sometimes happens with interventions that are delivered at a population level, where the advantaged are able to access the intervention more quickly, more easily, and thus their health improves at a faster rate than the disadvantaged. Absolutely. Thank you so much for that, Donna. Our group is doing a lot of work around this applicability issue in terms of extrapolation. That is the application of results to a wider population than that studied. So looking beyond to infer, predict, extend, or project beyond what was recorded. And the way that we're doing this is asking, when is there no good reason to expect that an intervention will not work in vulnerable populations? Some examples that we've looked at are tamoxifen for early breast cancer and antibiotics for otitis media. So for example, with tamoxifen, assuming that there's an equal access to care, there's no reason to think that if tamoxifen is given for the right form of breast cancer, that it would work any differently in a woman from a low-income country, or an illiterate woman, or a woman disadvantaged in another way. However, with antibiotics for inner ear infections, it's a different story. In low-income countries, the strain of strep that causes rheumatic fever is far more prevalent than the strain of strep that usually infects kids in higher income countries. Thus, untreated strep in LMICs is more likely to have serious consequences. Therefore, you might be more likely to prescribe antibiotics in a lower or middle income country than in a higher income country. So can it be extrapolated? How do you determine this? How do you know when? We're doing some work developing applicability checklists from clinical epidemiology, looking at developing an algorithm for when one looks at systematic review results and determining how to apply it to different populations. We also look at generalizability rules from social sciences and other ideas from other disciplines. So, what can equity do for you? It can increase the relevance of your review for disadvantaged populations. It can help practitioners decide whether the results of systematic reviews can be applied to their practice populations. It can address the needs of policymakers looking at equity issues. I'd like to open the floor to any questions from the group as a whole. Any questions on applicability or extrapolation? Questions on equity and systematic reviews? When or how? I think we've covered the why, but if you have any questions regarding equity, I'd like to open the floor. I'm waiting for a response from David Morrison there. So we've opened the chat room so that if you'd like to use your microphones, you can feel free at this time. David Morrison's written in saying, what do you do when there aren't ample studies that address these subgroups, which tends to often be the case? So what do you do when there's insufficient data or not enough studies that address these subgroups? Identify a research need. I'd like to open that to the group. Does anybody have suggestions on how you've dealt with this when there's insufficient data from the primary studies, or how you would approach the subgroups? I see information from Carmela saying look for ongoing research and trial registries. The other thing you can do is look at methods for extrapolation, because there are many studies that will not be repeated. There won't be sufficient funding, or perhaps there's no need to. If a study has been done in balding fat white men from North America, as an example, perhaps the study doesn't need to be repeated to know whether or not it might apply to women in Southeast Asia. So looking at issues around how to decide whether those results could be applied are very important. And David, if you're interested in learning more about extrapolation or discussing that with our group, I'd welcome a conversation with you afterwards. I'm waiting for David and Donna to type in. Peter's told us a story many times when he was at a conference in the United States, and he was told by one particular group that they would not fund any studies that did not include or that were not addressing Black Americans, which of course raises some interesting issues around including every population in every study. Don has noted highlighting the gaps. If the research question is framed with equity in mind, the research gap might be a finding, and or highlight gaps in the policy implications in the discussion. Absolutely. And often when we're looking at equity in subgroups, the discussion is a fantastic place to identify those gaps and those needs. I've seen David suggesting, would it be worthwhile to mention in the initial review to encourage research interest? Cochrane reviews being updated every 3 years. Absolutely. In the update, those issues could be addressed as well. Any other comments or recommendations from the group? If you'd like to ask a question, please feel free to raise your hand, or feel free to send it over to Adrian if you have a question.
Well, thank you, everyone. I think that's been quite a lively discussion. I appreciate your participation today, your time in the chat room, and interaction with Erin. Why don't we give a round of applause to Erin. Erin, thank you so much for your presentation today and for facilitating the discussion. Absolutely fantastic, and we certainly appreciate your expertise in this area and speaking to us today. If that is it for the questions and comments, I will bring this session to a close. Just before you leave, however, I would appreciate if you could fill out an evaluation form. Let us know if any improvements that we can make to conducting these webinars through Illuminate. If you have any suggestions for future topics, I would welcome them. If you wish a copy of today's PowerPoint slides, we are happy to provide that to you. You can simply email us at ccnc-iph@uottawa.ca. Well, thank you all very much for your participation, and have a wonderful day.